Hello, everyone, and welcome to our talk on sleep disorders in Consult-Liaison Psychiatry. I am Dr. Mira Zein, a clinical associate professor in the Division of Medical Psychiatry at Stanford. So, why are we talking about sleep? For consultation-liaison psychiatrists, understanding sleep and sleep disruptions can help diagnose underlying medical and psychiatric causes, make recommendations for effective interventions, and improve patient outcomes in medical and surgical settings. Disrupted sleep is common among medically ill patients, and we regularly engage with patients at higher risk of developing sleep disorders, including patients in critical care units, patients with cancer, and peripartum and perimenopausal patients. Sleep disorders also have a bidirectional relationship with physical and mental health. Disruptions to sleep and circadian rhythms are core features of almost every psychiatric disorder and can exacerbate existing psychiatric symptoms. For instance, poor sleep is linked to a higher risk of developing depression and anxiety and can precipitate mania and first episode psychosis. Poor sleep will also lead to delayed healing, worsened immune responses, higher risk of delirium, and chronically will contribute to higher rates of cardiovascular and metabolic diseases. At the same time, poorly managed physical and mental symptoms can lead to worsened sleep, causing an ever-worsening spiral. And lastly, sleep management is a common inpatient and outpatient consult question. And so CL psychiatrists play a crucial role in working with medical and surgical teams to address sleep disturbances in their patients. And yet there's limited education on sleep medicine and psychiatry training and limited literature on sleep disorders in the CL psychiatry literature. So I'd like to introduce our group of speakers, and I'm humbled to be joined by such intelligent and dedicated colleagues. First, Dr. John Soleil is a recent graduate from the CL Psychiatry Fellowship at Stanford University. He has clinical interests in neuropsychiatry and the application of technology to medicine. He just started his new position at Santa Clara Valley Medical Center, and he will be presenting on the neurobiology of sleep and highlighting areas of sleep neurobiology that can inform new interventions. Next, Dr. Matthew Gunther is a clinical assistant professor in medical psychiatry at Stanford and assistant program director in the CL Psychiatry Fellowship and works with me in our IBH program in primary care. Dr. Gunther will focus on sleep abnormalities in the critical care setting and review evidence of different agents on sleep patterns and sleep treatment in the ICU. As I mentioned, I am a clinical associate professor in medical psychiatry at Stanford. I completed a year-long training in women's mental health and serve as the psychiatric director for Stanford's IBH program in primary care. During my presentation, I will explore the neurobiology and treatment options for sleep disruptions in the peripartum and perimenopausal periods. And lastly, but not least, Dr. Sheila Lahijani is a clinical professor in medical psychiatry at Stanford and a nationally recognized leader in psycho-oncology. She's the medical director of Stanford's psychosocial oncology program and is a section chief of psycho-oncology in the Division of Medical Psychiatry. Dr. Lahijani will be presenting on the impact of sleep disorders in patients with cancer and associations between sleep disruptions with symptom burden, health-related quality of life, and carcinogenic processes. And now I will turn it over to Dr. John Soleil to discuss the neurobiology of sleep.
Hi, everyone. Today I'm walking you through the neurobiology of sleep. Every 24 hours, your brain hands the keys to a night crew that cleans, rewires, and rehearses. 2 switches hand power back and forth. One keeps you awake, one puts you to sleep. Around those switches run clocks, pumps, and relays that sculpt NREM and REM sleep. We're going to scroll through with animations I've put together to help us visualize what's going on. So let's dive in. I have no disclosures. Up top is process S and C over a 24-hour day. Bottom left shows our wake and sleep promoting systems and their related neurotransmitters. On the right is brain network activity in varied brain regions. As we scroll through the day, we'll follow along with process S and C dynamics, watch systems light up and dim in the left panel, and network connections glow and fade on the right. We'll watch these 2 drives build towards sleep, see the machinery they control, and ride through a 24-hour cycle together. Take a look at the graph on the top. Process S is an adenosine, and it accumulates. It rises with time awake with local synaptic use. Watch the blue curve climb from 7 a.m. toward evening. That's sleep pressure stacking up. Every hour awake, adenosine builds in the preoptic area and cortex, creating mounting pressure to sleep. The longer you're awake, the higher it climbs. Process C is the circadian pacemaker in the suprachiasmatic nucleus, a molecular clock tuned by light. See the yellow wave on the graph? the suprachiasmatic nucleus delivers a daily timing signal to hypothalamus and brainstem, opening the sleep gate each evening. It doesn't create sleep pressure. It gates when sleep can happen. Sleep onset requires both high pressure from process S, meaning an open gate from process C. But what are these two processes actually controlling? Look at the left on the neurotransmitter panel. These are the wake-promoting systems running all day. Norepinephrine from locus coeruleus, serotonin from dorsal raphe, dopamine from ventral tegmental area, histamine from tuberomammillary nucleus, plus acetylcholine from the bacillus minor, all keeping cortex fast and reactive during wake. Right now, mid-morning, they're firing strong. Let's shift to brain network activity on the right, and the hypothalamus. In the hypothalamus sits the coordinator, orexin. Orexin typically excites all of them, all of the brainstem areas, keeping them stable and awake. When orexin neurons are impaired, like in narcolepsy, this stabilizer collapses. But as long as orexin is awake, so too is the brain. That's the machinery we'll watch fade as the day wears on. Let's move forward to about 10 p.m. together. Process S is near the peak, and you've been awake since morning. Adenosine is stacking, and you're definitely tired. Process C is dipping, meaning the circadian gate is opening. Suprachiasmatic nucleus is dampening orexin output, and melatonin is rising. Here's the convergence. Look where the blue and yellow curves meet. Homeostatic load peaks just as circadian timing permits sleep. The two processes align, tipping the balance towards bed. But what's being tipped? Look back at the neurotransmitter panel on the left. Norepinephrine, serotonin, and orexin all dropping as the day wears on. Now look at the brain network. Arousal centers are fading, and ventrolateral preoptic nucleus is ramping up. The wake machinery we met earlier is shutting down under rising adenosine pressure. Sleep onset is now imminent. It's just after 10 p.m. and convergence has hit its tipping point. GABA and galanin neurons in the ventrolateral preoptic nucleus that inhibit arousal hubs begin to hum. You can see them lighting up in the hypothalamus in our brain network. Because sleep systems inhibit wake systems, and wake systems inhibit sleep systems, it flips very sharply. Either wake is on or sleep is on. Ventrolateral preoptic nucleus fires, inhibiting the arousal centers, wake pathways dim, and arousal systems go quiet. With the switch flipped, the thalamic reticular nucleus, or the TRN in our brain network activity, closes the sensory gate, generating rhythmic spindle bursts. These are 11 to 16 Hz oscillations via rhythmic inhibition of the thalamocortical relay cells, blocking sensory input. The spindles protect cortex from external noise while coupling with hippocampal sharp wave ripples for memory consolidation. We'll see more of this in just a moment in section 2. At this point, the sleep workshop is open. Looking back at our graph at the top, let's move to about 2 a.m. Process S is falling, and sleep clears adenosine, and process C stays low, meaning the sleep gate remains open. Down in the brain network, VLPO continues to hum. Thalamic gating is underway, and we're cycling between non-rapid eye movement and rapid eye movement. The night crew has definitely settled in at this point. Let's go to 7 a.m. Process S has decayed exponentially, indicating clearance of our sleep debt. Process C is now rising, closing the circadian gate. Alertness signals are increasing, and you can see the brain network arousals reactivating. Norepinephrine, serotonin, orexin, dopamine, and acetylcholine all climbing. The first switch flips back and wake returns. With the onset of day, the night crew clocks out, and day shift takes back over. Now, let's zoom in to what happens inside one of those sleep cycles. Up top is a hypnogram. This is going to anchor our 90-minute cycle lap throughout the night. The middle stack holds regional EEG traces, frontal, parietal, hippocampal, thalamic, and brainstem, so you can watch networks take turns. Along the bottom is polysomnography, EOG or eye movements, EMG, muscle movements, and EKG are cardiac and respiratory. Layer on the right with a spectral balance map that shows which frequencies are humming when throughout the brain. As we slide across the cycle, feel how the rhythms hand from the baton from team to team and how the physiology follows suit. Let's walk a lap and meet the crew. Focusing on the hypnogram at the top, we're starting with wake, eyes closed and calm. In the central EEG, you can see alpha rhythms dominating. These are 8 to 13 Hz oscillations generated by thalamocortical loops when sensory systems idle. Beta at 13 to 30 hertz flickers in just enough to keep us responsive. Down at the bottom, check out the EMG and EOG traces. Muscle tone is present and eyes have movement. We're awake, but resting. As we scroll forward, watch the hypnogram dip into N1. This brief transitional stage is a boundary between wake and sleep. Alpha is folding back, and theta rhythms are rolling in. Slower 4 to 7 hertz waves paced by hippocampal septal circuits, signaling light sleep. Amplitude slides down and frequency slows. Look down at the traces. Eye movements show slow rolling and EMG softens, but still holds some tone. You're light enough to wake with a whisper, yet unquestionably descending. Let's dive further into stage 2. In the EEG stack, 2 hallmarks announce it: sleep spindles and K complexes. You might be able to see these better in the polysomnography EEG since there's a bit less noise. Those waxing and waning spindle bursts are 11 to 16 hertz oscillations erupting from the thalamic reticular nucleus rhythmically, and this clamps the thalamocortical relays. As we noted earlier in section 1, their role is to gate sensory input to cortex so as not to wake sleeping beauty. Together with K complexes, these define N2. As we continue, N2 deepens. Spindles shifts roles from gatekeeping to archiving. At this point, you can see hippocampal sharp waves ripple, lock onto the spindle rhythm, replaying daytime traces into neocortex. High spindle density tonight means better declarative recall tomorrow. Moving even further, we're now going to reach stage 3, the deepest stage of sleep. In the EEG stack, delta power now dominates. These are slow, 0.5 to 4 hertz waves representing vast neurons, assemblies depolarizing together and then entering downstates. Deep valleys and tall peaks means this is a heavy maintenance mode, driving lymphatic clearance and synaptic homeostasis. Let's move to the delta maps on the bottom right. Frontal cortex, the workhorse during daytime executive tasks, is now glowing with its highest amplitude. Learn a motor routine and the corresponding motor strip brightens just as bright. The brain brilliantly clears what is used most, precision housekeeping targeting the most active regions. Hopping back to the polysomnography traces on the left, eye movements are nearly flat, muscle tone is low but present, heart and breathing slow and steady. The cortex runs deep, slow waves while the body slips into quiet standby. Jumping back up to the hypnogram together, it's lifting from M3 as delta eases and theta begins to surface. After roughly 90 minutes of NREM, the second switch is winding up. On the brainstem schematic, inhibition pulls off the REM off cells, and this is the middle green slide, in the ventrolateral periaqueductal gray and lateral pontine tegmentum. The brake is coming off. Watch the hypnogram as we shift from blue to green. We're now in REM. In the brainstem panel, the sublateral dorsal nucleus ignites, driving glutamatergic projections that recruit inhibitory interneurons in the ventromedial medulla and spinal cord. Trace that glowing pathway running down the spinal motor pools, and that's atonia circuit, pooling up, paralyzing the body. With hypnogram locked into REM, look at the EEG stack. It flips to theta and gamma. The cortex looks wide awake, but down in the EMG line, it bottoms out completely, and atonia is fully underway. On the EOG trace, you can see rapid eye movements beneath closed lids. In the brainstem, pedunculopontine and lateral dorsal cholinergic cells are driving the circuit, while hippocampal theta synchronizes the cortical activation. This is essentially a rehearsal mode. Synaptic editing, emotional integration, and storyboarding memories are all going on. As we continue to scroll, REM winds down. Watch the hypnogram as it eases back toward a lighter stage. The REM off cells in ventrolateral periaqueductal gray and lateral pontine tegmentum reactivate. The sublateral dorsal quiets, and EMG tone returns. Our second switch clicks back. At this point, the cycle is complete. N2 spindles gated noise and filed memories, N3 slow waves scrubbed and reset, and REM theta rehearsed connections under enforced stillness. We repeat this 90-minute choreography for 4 to 6 times per night, each lap tuning different networks while the next shift rotates teams through their jobs. Finally, let's follow the plumbing that keeps the stage clean. This information is fairly new and still somewhat experimental, but I think it's worth sharing together. At the top, you'll see a 50-second norepinephrine oscillation. This is our metronome for the whole system. The middle pair of views shows a cross-sections of longitudinal cuts of the perivascular sleeves where cerebrospinal fluid flows. Along the bottom, blood and CSF volume graphs seesaw in opposite phases. You'll watch norepinephrine rise and fall, vessel walls pulse, and the volume traces trade places. These are the proposed mechanisms behind lymphatic clearance. Watch the norepinephrine trace at the top as it climbs toward its peak. As norepinephrine tops out, smooth muscles in the arterial walls contract. See the vessel walls thicken inward in the cross-section? The lumen tightens down, pulling tension into the system. Now take a look at the bottom panel. Blood volume drops in orange, cerebral spinal fluid surges in teal. Why is that? Our closed skull with a fixed volume means any fall in blood means CSF is forced inward. That's the wash cycle starting and fluid flooding in to fill the space. Now watch what happens as norepinephrine falls. Vessel walls relax and the cross-section opens back up. Flow vectors pulse along the perivascular sleeve, pushing fluid and waste down the drainage pathway. That alternating stretch and release, contract, and relax, pushes fluid through the parenchyma with each beat. Only 20% volume swings, repeated thousands of times per night, drive the lymphatic route. Now look back at the norepinephrine trace at the top, and I want you to take note of the microarousals, the sigma flickers. These arousals are linked to each 50-second cycle. The system isn't running on autopilot. It's breathing in these infraslow oscillations beneath the delta bath we saw in section 2. These microarousals are not interruptions, but in fact requirements. Each brief locus coeruleus burst brings cortical tone just high enough to maintain rhythmic coherence across the lamicortical loops. True sleep needs these spurts of wakefulness. Without them, oscillations desynchronize and restorative functions collapse. Sleep, almost paradoxically, is an active state. Wake regulates its depth, and sleep regulates the stability of wake. What is interesting is that optogenetic pacing of the locus coeruleus in mouse models at this exact 50-second frequency boosts CSF inflow. Speed it up or slow it down, and the effect is totally vanished. Frequency matters, amplitude matters, and the integrity of slow wave sleep matters. So while spindles are filing memories and slow waves are resetting synapses, the locus coeruleus is conducting a vascular orchestra, pulsing vessels, cycling fluid, and washing the parenchyma clean. 3 jobs, 1 night shift, all running in parallel. The brain doesn't rest. It spends its time reorganizing. So let's put all of this together. Every night, your brain executes a precisely choreographed handoff. 2 processes converge. Adenosine-driven sleep pressure climbs all day with a circadian gate opens at evening. When they align, the first switch flips. Ventrolateral preoptic nucleus inhibits arousal centers, thalamic reticular nucleus closes sensory gates, and the night shift clocks in. Once inside, the crew runs a 90-minute loop, 4 to 6 times per night. N2 spindles couple with hippocampal ripples, filing memories into long-term storage. N3 slow wave sleep across the cortex, resetting synapses and preparing circuits for tomorrow's learning. Then the second switch flips. Sublateral dorsal nucleus triggers atonia, while cholinergic brainstem nuclei reactivate the cortex. REM sleep rehearses, integrates, and edits under enforced stillness in the body. And underneath all of that, the locus coeruleus runs an infraslow metronome. Every 50 seconds, norepinephrine pulses, vessel walls contract and relax, and cerebral spinal fluid surges through perivascular channels, washing away metabolic debris the day shift left behind. It's 3 acts in 1 night. Clean, rewire, and rehearse. It's all really pretty cool stuff. And the more I learn about sleep, the more I wish I was awake to witness it. Thanks so much for listening.
Thank you so much, John, for a fantastic talk and for using such an innovative way of presenting. I'm now going to turn it over to Matthew Gunther to talk to us about sleep and sleep disruption in the critical care setting.
Thank you, Dr. Zein. So again, my name is Matt Gunther, and I'm going to be talking about sleep in critical illness. We'll talk a bit about mechanisms, ways to manage this, and also how to tie this into the neuropsychiatric sequelae that we see in critical care populations. I have no disclosures. So I want to talk a bit about in the ICU how ICU sleep differs from physiologic sleep. One thing that gets conflated quite often is sedation versus sleep. So how do we look for that? How do we conceptualize that when we look at the pharmacology and what's going on with the patient medically? I also really want to tie sleep and delirium together. Really, you can't talk about sleep in the ICU without talking about delirium. And so they really are intertwined, and you'll see how that comes into play in a second, and also how the two really can contribute to PICS as a syndrome, in particular the development of PTSD after an ICU stay. We'll talk a bit about the various agents that are used, both ones that we will consider as ones that the ICU colleagues are prescribing and using for sedation, how they look in terms of the sleep side of things. And then we'll think about ways that we can improve circadian alignment and reduce delirium burden by both pharmacologic and non-pharmacologic strategies. So in the ICU, what does sleep look like? Well, to be concise, it really is disrupted across all of the stages, in particular with reduced or even absent deep sleep and REM sleep. Part of this is confounded by the fact that there's frequent daytime dozing. If you picture folks in the ICU setting aside the sedation part, there's a lot of micro sleeps or little naps that people take, and this really compounds the impact that the sleep disruption has on the restorative value of sleep in it of itself, as well as the function in terms of the next day. I mentioned sedation and sleep are often conflated. So how do we actually assess if a person is sleeping in the ICU? It's really very hard. The actual measurement tools that we have are pretty limited. Things like EEG and other ways to objectively measure sometimes are limited by the patient population itself. So a lot of the times teams will say, no, it seems like they're sleeping just fine. But in reality, what they're looking at might just be the RASS score or the fact that they're on some level of sedation. So just keep in mind that just because someone looks like they're resting or somnolent or sedated does not equate to having the actual physiologic sleep stages that the body needs to recover. Pharmacologically, there are very few things that actually promote biomimetic sleep in the ICU, so we're working with a limited toolkit. The risk profile in terms of sleep disruption in the ICU are multifactorial. Part of them are iatrogenic in terms of what we're doing to the patient with pharmacologic choice. Part of it is related to the medical conditions. And also one thing I really want to point out is the concept of what is the person bringing into the ICU stay in terms of prior sleep structure. I think one thing we forget to ask about is when we're talking about someone with poor sleep in the ICU, what was their sleep like before? Were they using 3 or 4 agents to help with sleep? Are they already on a reverse sleep-wake cycle at home? So a lot of things to consider, but this list is something to refer back to in terms of ways of potential intervention. This was just a study done a year ago that really clarifies and elucidates the disruption sleep cycles in the ICU. You can see a healthy participant on the top and the bottom three being some level of ICU care, whether that's respiratory failure, weaning, or right after extubation. And you can really see how the deep stage and REM sleep cycles get completely disrupted and atypical sleep percentage goes up. So certainly it depends on the pathophysiologies that are going on with the person, but the take home is that things are very, very fragmented. So what are the consequences of this? There are both short and long-term consequences, higher delirium risks, certainly. One of the things I really want to emphasize in this talk is that sleep disruption is tied into delirium risk. And other things that are also impacted in terms of length of stay in the ICU, number of ventilator days, etc. When we look at folks with impaired sleep in the ICU, that is directly correlated with their ability to participate in therapies. And I mean physical and occupational therapy. We know those are the gold standards for improving delirium outcomes and helping a patient progress. And the sleep quality the night before and in a stacking fashion the nights before can really impact how well that person's able to maintain that engagement. Part of that might be driven to kind of the multifactorial medical and endocrine things going on, but also there's a lot of emotional disruption that comes with poor sleep. I think we all can relate to that, but even in the form of anxiety, depressed mood, things like that, feeling like one isn't progressing, that type of emotional dynamic can be compounded by poor sleep. And just keep in mind the concept of PICS and kind of the outcomes after the ICU. I think what I struggle with as a critical care psychiatrist is there's a small amount of data for what we do in the ICU in the acute stage, but really it's the long-term outcomes that we're trying to mitigate as critical care psychiatrists in terms of preventing too much of a burden in that way. And I think if we conceptualize that and think about that, it makes our kind of rationale for what we're doing in the ICU that much stronger. So I alluded to the fact that there are multiple impacts from poor sleep, and this really goes back to the idea of sleep being one of the categories of things that's related to the circadian rhythm. So I mentioned this is a sleep talk, sleep is disrupted, but as we just discussed, circadian rhythm is above that in terms of what is being disrupted, and it has a downstream effect on multiple functions of the body beyond sleep, including multiple endocrine related things, recovery, etc., that you can allude to here. So by trying to correct sleep patterns, we're also trying to correct circadian rhythm, which then will impact these other organ systems and parts of the person's recovery. So important to remember. We can't talk about ICU settings without talking about ventilatory support in people undergoing respiratory compromise. And you can really think about sleep and respiratory compromise in two kind of subcategories. We have the under assistance category where folks have a lung-brain mismatch in terms of dyspnea and air hunger and feeling like one has increased work of breathing. And then there's the other side where there might be over assistance from the ventilator combined with excess sedation, where there's microarousals or related to apnea, which I think we're familiar with in terms of the sleep apnea syndrome. And so both of these contribute to the potential for sleep disruption, in particular targeting REM sleep. And I alluded to kind of the under assistance being related to air hunger. On the over assistance side, this can really be seen in folks where the sedation level is too high. And part of what psychiatry can do to guide this is to help kind of target the ideal sedation to have people be comfortable but awake during the day so they can participate, and then more comfortable but a little bit tired at night, as opposed to kind of having a steady state level of sedation throughout the day that might be too excessive. When we look at sleep, it's directly related to one's ability to participate in ventilatory wean the next day. One of the most common consults we get in the ICU at Stanford is help with ventilatory weaning, trach collar trials. Well, one of the first things we should look at is how is their sleep, because that is something that we can really do that will then affect the subsequent days in terms of their participation in the ventilatory weaning process. I talked about delirium and sleep briefly, but I really want to emphasize this because it is tied together and they really are inseparable. When we look at consults in the ICU for delirium, you can look 2 or 3 days or a little bit more preceding that and see that the sleep disruption was really the harbinger of bad things to come. So this is really a point where we can intervene as CL psychiatrists, is identifying this and really focusing on sleep. When folks have sleep deprivation, they're 30% more likely to have mental status changes, including delirium. Part of that is all intertwined with the endocrine changes like low melatonin and high cortisol. But we do know that a huge portion of people, up to 80% of people in the ICU, are delirious at any one point in time. And a large portion of those people go on to develop a PTSD syndrome, with maybe a third of people in the first 2 weeks after recovery and maybe up to a quarter of people kind of in a longer term time span. So this is what I was alluding to when we might make changes acutely, but we're looking at mitigating the negative effects in the long term, and a lot of that can do with PTSD secondary to delirium. So what contributes to that development? We talked about sleep deprivation, but a lot of that is also related to sedation and the depth and choice of sedation agents that are used. And I'll talk about that in a second. And so being mindful of this concept can help, again, strengthen our rationale for when we're intervening on these cases. So what are the guidelines related to sleep in the ICU? The SCCM is the body to look at in terms of who's producing recommendations for ICU teams specifically about this. And the PADIS guidelines in 2018 were kind of the core feature of this, with a recent update back from February 2025. And what they comment on as part of this acronym, with S being sleep, are a couple things. One, recommending melatonin over no melatonin for patients in the ICU. 2 preferring dexmedetomidine over propofol for sedation. And so these two things you'll see will play into the concept of addressing ICU-related sleep problems. But it's important as consulting psychiatrists to be aware of these guidelines. ICU teams in general are very guideline focused, and we've had feedback as critical care psychiatry teams at Stanford that being aware of this is helpful, but also being able to mentalize with teams that prioritize guidelines over everything else can really help when you're addressing these consults. So what has evidence for non-pharmacologic sleep support? Well, it's really the combination of a few things. Eye protection, ear protection, helping kind of inform and support a regular sleep cycle as much as possible. Having music going in isolation, they don't really show to be as effective as they do in combination. But the idea is if we can support kind of the darker nights and brighter mornings as much as possible, then we're able to kind of start to fix that melatonin dysregulation that we see in folks in this way. This is part of the bundle and the ICU bundle that we think about when looking at folks in the ICU that's encouraged. The actual evidence, again, for sleep is a little mixed in terms of these things, and some of these, as you can see, might be logistically hard to do in the ICU. But again, going back to the delirium and sleep being intertwined, these bundles and these changes can help reduce the delirium burden. So again, maybe addressing both at the same time. So pharmacologically, there's not much that has consistent benefit for helping sleep quality or clinical outcomes related to sleep in the ICU. A lot of it has to do with things that are not contributing in a good way, sort of negative contributions. GABAergics are at the top of this, decreasing all stages of sleep when they're used. These are things like propofol, benzodiazepines. Slow wave sleep in REM gets suppressed. The amount of time spent in REM sleep is decreased with propofol use. Opioids similarly are not great at sleep architecture, affecting both deep and REM sleep. And so these two kind of combine to wreak havoc when they're used on ICU populations. Also, the idea of the cumulative exposure and the amount of milligrams and for how long one is exposed to these is directly correlated to the development of delirium, partly due to the formation of delusional memories and then subsequent PTSD. And so these agents, GABAergics and opioids in particular, can be really problematic on multiple fronts. The one that is more reassuring is dexmedetomidine, which is an alpha-2 agonist. Hopefully we're all familiar with at this point. When they've looked at studies of patients in the ICU for those on dex versus not on dex, or on propofol, for example, it does show that to be the most biomimetically similar compared to someone undergoing healthy sleep in terms of what sleep stages it promotes, increasing stage N2 and N3. Its evidence on affecting REM is a little less robust, but overall it's the best that we have. And we really do encourage when we're looking at sleep promotion in the ICU, this idea of dex cycling. So you're aiming for a RASS of 0 during the day until it's nighttime, and then you adjust the dex to reach a RASS of -1. Again, this idea of balancing too much sedation with alertness during the day is very important. Interestingly, dex also has some effects on development of PTSD compared to placebo, so it might help in that regard too. This is just a summary. I'll leave this for you all to look at the main sedative agents in IV form that are used in the ICU. I will just reiterate that dexmedetomidine is the one that is the most reassuring and also has some effect at mitigating the delirium burden as well. So when we look at tapers of sedation, we really shouldn't be reducing all 2, 3, 4 at one time. You should be prioritizing keeping the alpha-2 on for the very end. Now, what about other agents, oral agents that are used for sleep? Overall, you'll see that the data set is pretty low, but there are some things where they might be helpful. So melatonin, right, was recommended by the PADIS guidelines. There's really no evidence that it helps in terms of subjective improvement in quality or quantity of sleep. It might have an impact on delirium. Same with Ramelteon, where it's reducing delirium risk in ICU populations, but its effect on sleep specifically is not as robust. So again, tying it back to delirium. Orexin antagonists are something that are being used more and more often, certainly at Stanford. It's part of our house wine, so to speak. And again, it's more effective for delirium than it is for sleep. But again, think of delirium as a circadian rhythm problem to begin with, and you kind of begin to link the two together. There are no guidelines to discuss the idea of antihistamines antipsychotics in terms of sleep promotion. A lot of these things are being generalized from non-critically ill populations, and I'll talk about how to think through this in a second. This is another summary table that you can all look at, looking at kind of the risk profile of every agent, but I'll leave that here for now. So how do we tie this all together? Taking the fact that one, folks have really troublesome sleep in the ICU, if you can identify that to begin with. Well, that is the first step when you have a consult in the ICU for sleep disruption. What is the pattern? Is it just nocturnal fragmentation and during the day is okay? Is there this 24-hour imbalance of behavioral discontrol leading to poor sleep? Or is this more of a flipped sleep-wake cycle where someone is hypoactive during the day and hyperactive at night? Because that'll inform how you should approach it. So asking a lot of questions related to that. Fix the environment first. The idea of not interrupting a patient in the middle of the night in the ICU is, I think, an optimistic goal. It certainly is one that we can, inquire about, but you can introduce these non-pharmacologic measures that I talked about. Psychoeducation, a big thing to do for patients and families at bedside, because family and caregivers at bedside, because they love to feel empowered and serve as advocates for their patients. So if they can build in some anti-delirium related activities like reorienting the patient, keeping the windows open, helping them stay stimulated during the day, that can actually have a big impact on sleep and delirium outcomes. I alluded to the DEX versus other sedative kind of piece of things. DEX should be prioritized as the last thing to come off, hemodynamics aside, and then the propofol, the GABAergics, followed by the opiates should be the things that are prioritized. Sometimes teams are doing things kind of a little bit for each one over the course of a day, but we really do emphasize the DEX should be the one that comes off last. And be mindful of level of sedation and sleep. Can we enforce this idea of DEX cycling and having RAS be more robust during the day and lower at night? What about pharmacology? There, again, the data to support which ones to pick over another, it's pretty difficult to say in terms of having a robust evidence base for our ICU colleagues. But on our end, we try to pick things that might be multifactorial in terms of benefit. Can we help with sleep and delirium burden with one agent, taking into account pharmacokinetics and pharmacodynamics of that patient in particular? Because in doing so, you might hit two birds with one stone. Chronobiotics, orexin antagonists seem like low-hanging fruit and reasonable with a bigger evidence base, but the rest just really isn't there, unfortunately. So to summarize, highly fragmented sleep in the ICU setting, multiple contributors to that, both what the patient brings in to the ICU setting, what we do to the patient, and then what develops medically. There's a big negative outcome to poor sleep that's related to the circadian rhythm disruption overall on the patient's functioning medically and in terms of restorative effects. Don't try to separate sleep from delirium. They really are intertwined, and by addressing one or both, you're addressing the other one by association. DEX should be prioritized, GABAergics should be deprioritized, and don't forget about the fact that the person being ventilated, that alone can kind of have a big impact on sleep. So a lot to be kind of elucidated and clarified. A lot of what we do in the ICU related to sleep and delirium has to do with generalizing what we know about medically ill populations, but more needs to be written on this topic, certainly. But I think we can do a great service to patients and help reduce their neuropsychological burden in the long term by making more thoughtful kind of recommendations and conceptualizations for these cases. So hopefully that was helpful. Thank you so much.
Thank you so much, Dr. Gunther. I will now introduce myself, and I'll be talking about peripartum and perimenopausal sleep disruptions. I have no disclosures, and so just a quick outline. We're going to do a few quick facts about estrogen and progesterone throughout a woman's lifespan, talk about the neurobiology of estrogen and progesterone on sleep, then do a couple of cases where we'll talk about peripartum and perimenopausal sleep, and then go into looking at treatments for each of those stages with a brief look at some new interventions. All right, so women experience unique sleep challenges across the lifespan, with hormonal changes during puberty, pregnancy, and menopause playing a major role in sleep quality and risk for sleep disorders. Insomnia, which we'll be focusing on, is much more prevalent in women than men, especially during these reproductive transitions, and is often accompanied by symptoms such as fatigue, mood disturbance, and restless leg syndrome and obstructive sleep apnea, which can occur more frequently in women as they age, with menopause increasing the risk for sleep disordered breathing, as well as insomnia due to vasomotor symptoms and hormonal shifts. Women often report poorer subjective sleep quality, even when objective measures on polysomnography show longer sleep duration and higher sleep efficiency compared to men. The main differences in sleep arise with the first menstrual cycle. With menarche, ovarian function increases and estradiol and progesterone are cyclically released into the bloodstream, and they regulate a large variety of homeostatic functions involving the cardiocirculatory, respiratory, metabolic systems, as well as sleep-wake cycle regulation. The most dramatic change in sleep across the menstrual cycle is the post-ovulatory luteal phase, particularly later in that phase, where we can see significant fluctuations, as you can see on the right, in progesterone and estrogen levels. In this part of the menstrual cycle, we can see increased EEG activity in the frequency range of sleep spindles of 12 to 16 hertz during non-REM sleep. The later post-ovulatory luteal phase corresponds to subjective complaints in studies of longer sleep onset latency, subjective lower sleep efficiency, and worse subjective sleep quality. As we can see, we're going to now move into pregnancy and perimenopause, where there are significant changes as well. So female sex hormones have a number of different potential impacts on circadian rhythms and sleep homeostatic mechanisms. Some postulated ways that estrogen and progesterone can impact sleep, including modulation of neurochemical transmission through direct adjustment of morphology of synapses and of neuroglia, particularly of astrocytes. Hormone response elements, such as estrogen response elements, can directly impact gene expression and have been found on clock genes. And estrogen and progesterone also impact sleep-adjacent behaviors such as nest building and circadian rhythms in different murine and other animal models, which result in longer duration of sleep and correspond to human studies where we see longer duration of sleep in women compared to men. Female sex hormones also can have impact on those systems that Dr. Soleil was talking about earlier. And so we can see estrogen and progesterone suppressing neural transmission of somnogens prostaglandin 2 and adenosine in the VLPO, which will weaken sleep drive. In particular, estrogen will have this impact on both very strongly. Both estradiol and progesterone will regulate histamine transmission for the tuberomammillary nucleus, as well as estradiol impacting noradrenergic activity in the locus coeruleus, serotonergic activity in the dorsal raphe nuclei, and dopamine in the VTA nucleus accumbens, as well as the basal forebrain nuclei for acetylcholine. Interestingly, the metabolite of prednisone, allopregnenolone, is a GABA-A agonist, so would impact sleep in a positive way, but the net seems to be that progesterone also will impact wakefulness and cause decrease in non-REM and REM sleep duration. So moving on, let's talk about our first case. This is a 36-year-old female. She was 32 weeks pregnant with her first child, and so she was brought up to her OBGYN during the visit that she was having ongoing sleep disturbances during her pregnancy. She had a lot of nausea in her first and second trimester, had some improvement in sleep initiation and maintenance during the second, but now in third was having significant difficulty with sleep initiation and maintenance. And so an e-consult was placed to psychiatry requesting assistance with pregnancy-safe options. On chart review, this patient was found to have peripartum hypertension despite no pre-existing hypertension pre-pregnancy. So sleep disturbances are commonly reported during pregnancy, affecting more than 1/2 of all women and increasing as gestation progresses. And so 78% of women in one poll reported more disturbed sleep during pregnancy than any other time during their lives. The third trimester in particular has the most robust change, with numerous studies showing an increase in wake after sleep onset compared to other trimesters. And the near universal presence of sleep complaints during pregnancy can lead to the belief that these symptoms are normal or to be expected. So that can impede accurate diagnosis of sleep disorders during this crucial time. One study found that fewer than 10% of pregnant patients were asked about symptoms of sleep apnea or other sleep disruptions by their obstetric providers. Factors contributing to sleep disruption in pregnancy are numerous, including nausea, nocturia, fetal movements, nocturnal oxytocin, gastroesophageal reflux, musculoskeletal discomfort, leg cramps, pregnancy-related mood and anxiety disorders, and exacerbation of underlying medical conditions such as asthma. There are changes in iron and folate metabolism in pregnancy, which can explain increased prevalence of restless leg syndrome. And of course, there are profound hormonal changes with exponential increases in secretion of estrogen and progesterone, which will impact circadian homeostatic sleep regulation. An emerging literature suggests that short sleep duration and the presence of sleep disorders during pregnancy can increase the risk of adverse pregnancy outcomes, including higher rates of C-sections, preterm birth, increased risk of gestational diabetes. From a psychiatric perspective, untreated peripartum sleep disturbances are linked to an increased risk of peripartum and postpartum depression, increased severity of postpartum psychosis, and increased risk of perinatal anxiety and OCD. Data linking sleep disturbances to adverse outcomes such as placental abruption, stillbirths, and shorter telomere length, as well as poor child outcomes, are emerging and need to be investigated further. And poor sleep may disproportionately affect pregnant women of lower socioeconomic status and racial minorities, groups that are already at increased risk of adverse pregnancy outcomes. Pathogenetic mechanisms beside all these associations that I mentioned have been postulated but remain to be proven, with the placenta and placental disruption as one possible mechanism. And other potential mechanisms noted in this figure include an enhanced inflammatory profile, endothelial dysfunction due to an enormous variety of hormonal changes that are happening, oxidative stress, and then there's an allostatic load hypothesis that's been proposed, suggesting that chronic sleep loss is both the precipitant of stress as well as a consequence, leading to a stress overload that can account for those adverse pregnancy outcomes. I just want to quickly highlight that there are particular risks of OSA in pregnancy. So there's a lot of predisposition in pregnancy for sleep-disordered breathing, including weight gain with central distribution, nasopharyngeal edema, decreased size of the upper airway, and decreased functional residual capacity. And so over 1/2 of reproductive age population in the US already begins their pregnancy overweight or obese, which leads to even more risk. And so these patients have an even higher risk of pregnancy-specific complications, including gestational hypertension and gestational diabetes being the highest ones. But a lot of our questionnaires aren't actually sensitive or specific enough for these patients. So one example, the Stop Baying questionnaire has a sensitivity of only 53% in pregnant women. And so you have to use data such as looking at chronic hypertension, BMI, age-predicted sleep apnea, and looking at the presence of frequent snoring to get better sensitivity for these patients. Our case had not been screened by her OBGYN for sleep apnea, and given her age, presence of gestational hypertension, part of the e-consult was to recommend screening of the patient for snoring to determine whether an OSA assessment should be completed. All right, moving on to case 2. So this is a 47-year-old woman who had 2 children in her younger years who presented to her PCP with concerns for excessive daytime sleepiness, poor concentration. She was requesting an evaluation for ADHD. She was referred to our IBH program for help with work and family-related stress. And on psychiatric consultation, the psychiatrist discovered sleep disruption due to hot flashes, as well as feelings of brain fog. And these had developed independent of her work stress over the past couple years. So looking at sleep disturbances in perimenopause, you have about 40 to 60% of perimenopausal and postmenopausal women reporting sleep disruption. And perceived sleep changes mostly relate to sleep fragmentation, increased awakenings, and poor sleep quality. Chronic insomnia can develop into up to 42% of women by the end of their menopausal transition. The extent to which sleep disturbed during menopause may depend on the severity of menopausal symptoms, as women with significant menopausal symptoms have vastly different subjective perceptions and studies about their sleep compared to women with a few symptoms. However, as this figure suggests, sleep disruption in this age is multifactorial and complex. When we look at hormonal correlates, we see that perimenopause is marked by dramatic hormonal changes, including increase in follicular stimulating hormone and a decline in estrogens and progesterone. There is correlational evidence of a relationship between these hormonal events and sleep, with decreasing estradiol and increasing FSH levels being associated with poorer sleep quality, and a faster range of change in FSH levels being associated with longer sleep and more non-REM sleep. Progesterone has a less clear relationship with these changes in perimenopausal sleep. The treatment with progesterone hormone replacement therapy can help sleep quality in conjunction with estrogen. Sex hormone shifts may also mediate circadian rhythm disruption. Another big component is vasomotor changes in sleep. So hot flashes, night sweats are hallmarks of menopause, and they likely play a major role in sleep disturbances in menopausal women. Current evidence suggests a consistent coupling of vasomotor symptoms and poor self-reported sleep quality, especially when these symptoms are reported as severe, experienced at nighttime, or associated specifically with night sweats. Polysomnography confirms sleep fragmentation, increased wake after sleep onset, and poor sleep efficiency with more severe vasomotor symptoms. And when it's measured objectively using skin conductance, similar findings of objective sleep disturbances are found. Sleep changes can also reflect an aging process directly. Aging in women has been linked independently with fragmented sleep, insomnia, circadian derangements, and sleep architectural changes. Aged women show reduced sleep efficiency, increased wake after sleep onset, and decreased slow wave and REM sleep. A longitudinal cohort study following premenopausal women at baseline after 6 years showed that both aging and hormonal changes impacted sleep architecture independently. Other potential contributing factors include higher risk of developing mood disorders in perimenopausal women, higher rates of restless leg syndrome and OSA, and perceived social stressors related to the experience of menopause itself. Moving on to treatment of sleep disruptions, there are two common threads that we can see across both peripartum and perimenopausal stages. The first is to encourage treatment of any underlying medical or psychiatric comorbidities that may be contributing to sleep disruption. As CL psychiatrists, this may mean working with patients and teams around decreasing obstacles for engaging in treatment, or direct treatment of mood and substance use disorders that might be contributing to poor sleep. A second common thread is that there is robust evidence for implementation of sleep hygiene practices, CBTI, and physical activity, as these have all been shown to lead to improvements in perceived sleep quality, total sleep time, and decreased awakenings after sleep onset in various studies. CBTI in particular is considered a first-line therapy in both peripartum and perimenopausal periods. And CBTI in comparison trials is superior to sleep hygiene alone and superior to sleep medication alone. For peripartum patients, CBTI is also superior to the smart bassinet interventions where you can have bassinets that change and help to regulate baby's sleep. Digital CBTI platforms, such as an app called Sleepio, delivered structured therapy via an app and via not having an actual therapist, but using an AI application, and has been demonstrated to be comparable to just regular CBT in early studies in peripartum mental health. Other things that you can do include relaxation techniques such as progressive muscle relaxation. And then there is something called PUMAS, which is perinatal understanding of mindful awareness. This was an intervention where you had virtual mindfulness-based interventions in the 6 weekly telesessions. And these early studies showed support in improving perinatal and depressive symptoms, as well as anxiety symptoms and improvement of sleep. Moving on to medication, we'll talk about peripartum patients first. When prescribing medication for sleep and pregnancy, it's always important to have a risk-risk conversation with expecting mothers to discuss the risks of using medication versus the risks of untreated insomnia, and to encourage considering treatment when non-medication interventions have failed and when there may be significant impact on the patient's physical and mental health. Antihistamines are the most widely used medications in pregnancy, with low dose over-the-counter doxylamine actually recommended as first line, given its concurrent use as part of a medication, perinatal nausea and vomiting. Low-dose TCAs such as nortriptyline, amitriptyline, and doxepin don't tend to be thought of, but they actually have pretty good safety profiles during pregnancy. Trazodone is a popular medication outside of pregnancy, but doesn't have great safety data in pregnancy, so isn't frequently used. And things like melatonin and ramelteon are actually not indicated due to a paucity of safety data. If needed, lorazepam and clonazepam can be used intermittently in the peripartum period, particularly with comorbid peripartum anxiety. Lorazepam generally preferred due to in benzodiazepines due to its lack of active metabolites and low relative infant dose. Observational studies and FDA labeling indicate that benzodiazepines are not clearly associated with major congenital malformations anymore, but use in especially late in pregnancy can result in neonatal sedation as well as a withdrawal symptom and respiratory depression. I love this image from this 2022 article in Biological Psychiatry that discusses prescribing sleep for postpartum depression. And this doesn't seem like it should be new or innovative, but it's something that pretty much nowhere except this one study in Australia did. And it reviewed the literature and showed that, the impact of acute and chronic sleep deprivation for postpartum women has such a broad range of impacts on postpartum depression, anxiety, infant health, and that these four prongs of really impacting maternal narrative and implementing interventions on a structural support section can actually lead to decreased maternal depressive symptoms, improvements in infant health, and then actually can improve economic and healthcare disparities for these patients over time. Looking at perimenopausal treatments, really menopausal hormone therapy is the most efficacious treatment. You don't have to think about the details of this because you most likely won't be prescribing them. But looking at treatment, there you can use transdermal or oral estradiol preparations. Transdermal can be less likely to increase the risk of venous thromboembolism. And then looking at progesterone's link is less clear, but there has been combination therapy has been shown to reduce vasomotor symptoms better than just estrogen alone. And the primary indication is really to alleviate moderate to severe vasomotor symptoms. Medications that we are more likely to be prescribing include low-dose paroxetine or low-dose venlafaxine. Low-dose paroxetine is approved as an only non-hormonal prescription therapy by the FDA. And then one RCT of 151 patients found that paroxetine reduced vasomotor symptoms by 40.6 to 51%. And then lastly, we have gabapentin, pregabalin, and clonidine, which are medications that have all been studied in low doses to be effective for vasomotor symptoms and have independent studies outside of perimenopausal patients for sleep, with only a couple small studies showing that independent of vasomotor symptoms, that these medications can be helpful for sleep as well. All right, so there are different wearables and other devices that are commonly called femtech. And so for perimenopause, cooling devices such as a wrist wearable are marketed. And there's a couple small studies that show using these wrist devices that can cool you can lead to a reduction in sleep onset latency, as well as an increase in nighttime sleep. There's also a cooling mattress pad system, and it has one very small study of 14 patients. And then there are apps that you can put in for sleep diaries in real time. So now moving on to concluding points, estrogen and progesterone have complex interactions with sleep mechanisms, and fluctuations in those hormones will lead to disruption in sleep throughout a woman's lifespan. Screening for sleep disturbances in understanding the presentation of sleep-related changes is important for both catching undiagnosed sleep and to address mental health issues. The cornerstone of treatment for sleep disruption includes treatment of underlying comorbidities, encouraging physical activity and CBTI. And for peripartum sleep concerns, medications should be utilized judiciously, and there should be a risk discussion with the patient. For perimenopausal concerns, the best evidence is for the treatment of vasomotor symptoms, with HRT having the best evidence. And novel mechanisms of providing therapy differ in their level of evidence, with digital CBTI having the most robust evidence to date. Thank you so much. And now I will turn it over to Dr. Sheila Lahijani.
Hello, I'm Sheila Lahijani. I'm one of the CL psychiatrists at Stanford. I'm a clinical professor and I'm the medical director of the Stanford Cancer Center Psychosocial Oncology Program. Today, I'll be speaking with you about sleep disturbances and disorders in patients with cancer. I have nothing to disclose. The relationship between sleep disturbances in patients with cancer is rich physiologically, psychologically, medically. A great majority of patients with cancer experience these disturbances and get diagnosed with sleep disorders, as many as up to 95% along the care continuum. Using the 3P model, otherwise known as the Spielman model, patients may have predisposing vulnerabilities, which may increase their risk for having sleep disorders as they undergo cancer care. There may be precipitating cancer-specific events related to the shock of the diagnosis and any treatment-related effects, as well as any perpetuating behavioral patterns that develop during the course of their cancer care that can contribute to disturbances in sleep. So it's multifactorial, related to stress, comorbid psychiatric symptoms or disorders, as well as the psychoneurological symptom cluster burdens of pain and fatigue, treatment-related side effects. And this can continue throughout care, as well as decades into survivorship. These sleep issues can persist and can really impact quality of life. There's some burgeoning area of research that has studying the impact of these disturbances and disorders on the treatment outcomes in cancer and potentially survival. So it's multi-directional, bidirectional, and we know that patients who have chronic sleep disturbances and chronic sleep deprivation can have a significant number of pathways activated, both neuroendocrine and inflammatory. This can potentially inform and influence the outcomes of cancer care. Again, studies underway and some data available suggesting that more studies are needed really to establish baseline sleep architecture and quantify chronobiology changes in patients with cancer and really identify early biomarkers in this patient population as well. Many patients suffer from cancer-related fatigue when they undergo cancer care, which is a syndrome, and up to 50% of patients with cancer experience comorbid sleep disturbances with cancer-related fatigue. There are strong correlations between subjective cancer-related fatigue experiences, as well as objective measures of sleep quality. And so there's essentially a self-perpetuating cycle where people are fatigued from the CRF and overall illness experience. They're napping during the day, which is then fragmenting their sleep architecture at night, perpetuating more fatigue, perpetuating more insomnia. And so identifying the sleep disturbances and disorders related to cancer-related fatigue can be very important diagnostically and therapeutically. And so as is the case with the general population, patients with cancer mostly suffer from insomnia at a rate of 3 times more actually than the general population. And many people also can suffer from OSA. The second most common sleep disorder in patients with cancer. And this is actually a separate risk factor for developing cancer, as has been studied over time, and a potential outcome or consequence of cancer diagnosis and treatment. Less common, yet still clinically significant, are narcolepsy, RLS, and REM sleep behavior disorders, which are also being studied in patients undergoing some of the newer cancer therapies. And so taking sleep apnea as an example, patients are experiencing oxygen desaturation, which is contributing to intermittent hypoxia, which is triggering more oxidative stress. Patients are already in a state where they're going to have stress, which is then going to contribute to the increase also of increased vascular endothelial growth factor, which both is helpful with respect to angiogenesis and yet unfortunately can contribute to tumor growth and metastasis. So as it stands, patients with OSA may have a higher cancer prevalence and incidence and mortality. OSA itself is associated with worsening, increased risk for cardiovascular disease, cerebrovascular disease, cognitive impairment, higher morbidity and mortality. So in sum, it's important to identify our patients with cancer who may also have chronic intermittent hypoxia as a way of optimizing their overall comprehensive cancer care. With respect to insomnia, patients are not sleeping. It's hard for them to fall asleep. It's hard for them to stay asleep. They have reduced total sleep time. They're waking up earlier. It's really difficult for them to have any daytime alertness. Cognitive functioning may be compromised. And so not infrequently, patients are prescribed different medications by their providers, oncologists, primary care providers, or otherwise. Other modalities include CBTI, which I'll talk about, and different sleep maintenance and sleep health hygiene techniques. So when we think about like the larger impact of sleep disturbances and disorder, namely insomnia and oncology, we must think about the multidirectional nature of people who suffer from this sleep disturbances and may have comorbid mood disturbances. So that can inform the development. Sleep disorders can inform the development of mood disorders. Mood disorders can inform how people sleep and really perpetuate those sleep disturbances. So it's really challenging often to diagnose depression, anxiety, sleep disorders, determining, what's primary, what's secondary. We do know, however, all of it can impact cognitive functioning and performance, and patients with cancer are already at higher risk. And one of the examples being chemo brain, which we know, and it can affect memory, concentration, as well as executive function. So it's important that we think about insomnia as independently predicting how someone's quality of life may be as they undergo cancer care, how much fatigue they may have, how much pain they may have, because all of it, as I mentioned earlier, can be self-perpetuating. And mechanistically, what's taking place, what's happening is this heightened systemic inflammatory response, where all these pro-inflammatory cytokines that are affecting the regulatory sleep centers of the brain, the different cytokines released from the tumors can also be crossing the blood-brain barrier, affecting sleep architecture. There's dysregulation of different hormones, such as ghrelin and leptin, that can affect circadian rhythm, and metabolic changes, such as shifts in pH, glucose, amino acids, PCO2, increased neuroexcitation and sleep homeostasis, as well as disruptions to serotonin, dopamine, GABA, noradrenaline. And so all of this can impact sleep architecture, sleep initiation, maintenance, etc. So if we think about the brain as being inflamed, when someone is going through cancer care, there's these cancer-related pathways that are contributing to this inflammation via peripheral inflammation, which I spoke to, as well as what's happening within the brain once the cytokines cross the blood-brain barrier, and then what's happening peripherally, release of ILB, interleukin-1 beta, interleukin-6, TNF-alpha in the circulation. So all of the different central sleep structures then get impacted, contributing to sleep disruption. We also know that the neurotransmitters are impacted by this tryptophan-steal phenomenon when there's a high state of inflammation. Indolamine 2,3 dioxygenase can be upregulated, which essentially shunts tryptophan away from the synthesis of serotonin and melatonin towards kynurenine pathways. There's depletion of central serotonin. There's also reduction in the synthesis of melatonin. And there's increase in the neurotoxic metabolites, such as quinolinic acid, too. So lots of neuroexcitation, increased experiences with anxiety, further worsening sleep. In addition, dysregulation and disruptions to the HPA axis that may be caused by stress, may be caused by pain, may be caused, practically by so many things, contributes to a flattened diurnal cortisol curve. And so there's increased cortisol that's happening at night. There's persistent hyperarousal, there's physiological arousal, which really compromises and contributes to poor sleep consolidation. There's chronic stress and inflammation that's continuing to also disrupt sleep. So with respect to different diagnoses of sleep disorders, it's important to think about what's primary, what's secondary. So primary insomnia disorder, primary sleep disorder, really precipitated by cancer and the cancer illness, and what's being perpetuated by different maladaptive behaviors or cognitive overload or hyperarousal. There may be sleep disorders related to pain, vasomotor symptoms, peripheral neuropathy. Patients may be experiencing sleep disorder secondary to the use of different exogenous agents such as steroids, stimulants. There could be withdrawal of different substances like opioids or benzos. Someone may be suffering from a depressive disorder. Someone may be suffering from GAD or PTSD or whatever the case may be, and insomnia is a feature of that mood disorder. And we know that patients who are sick and undergoing care in the hospital, outside the hospital, are exposed to so much that can affect chronobiology and affect circadian rhythm and OSA, which I spoke about earlier. So it's super important when we're encountering patients undergoing cancer care or patients who've historically had cancer to ask questions related to sleep. How are you sleeping? How have you been sleeping since you were diagnosed? How have you been sleeping since you started X treatment or since you finished X treatment? Are you satisfied with that? We can use different scales for screening, such as the Epworth Sleepiness Scale. We can use the Stop-Bang questionnaire, which can ask questions and screen for OSA. There are validated assessment tools. We always encourage and recommend patients use a gold standard, which is to do a sleep diary or log for 2 weeks, if possible. And then the use of the Insomnia Severity Index, which can suggest clinically significant insomnia with scores of greater than 14. The Pittsburgh Sleep Quality Index, which can assess sleep quality over a 1-month duration. And then we can refer to sleep medicine. And thankfully, I have wonderful colleagues here who are experts in sleep medicine and a sleep oncology clinic, actually, that's been developed here. So we refer many of our patients in instances where they need more involved evaluation and management. And so when we think about the etiology, we think about these different categories. How much of what someone is experiencing with respect to their sleep disturbances and disorders is directly a result of the tumor burden, the effects of the disease, what's happening systemically with respect to inflammation. Are there paraneoplastic syndromes? How much is related to treatment, chemo, steroids, hormones, radiation, surgery? What's affecting what's contributing to a state of hyperarousal or discomfort or changes in one's pain threshold? Psychologically, psychiatrically, what are people dealing with? Often it's anxiety or depression or both, fear of disease progression or recurrence, existential angst. And many people have comorbidities. Many people have comorbid disorders and comorbid symptoms that are contributing. So treatment, first line, is really the use and the adapted use of CBTI. So that includes three main components, which are cognitive restructuring, sleep restriction, and stimulus control. Cognitive restructuring is really with the aim and the focus of addressing the fears, the worries, the anxieties related to cancer. And then people are oftentimes very distressed that they may not be sleeping and they may be up thinking, and that's going to make the cancer outcomes worse. So addressing that component of it with the use of CBTI, sleep restriction, which we have to use with caution because really the goal is to consolidate sleep by limiting the amount of time people spend in bed while they're awake. And yet that's tricky when people are undergoing cancer treatment and are having significant symptoms and side effects, as well as symptom control, really adapting for the physical needs. Patients may use their beds for other reasons other than what is generally suggested, which is for sleep and or sex. And so really it's important to think about these different components and adapt them respectively to our patient population. Similarly, as it relates to the use of medications, there are many medications we can make use of, among which are mirtazapine, trazodone, and toxapen. Mirtazapine and trazodone given their H1, 5-HT2A antagonism. Mirtazapine can also be used for the symptom clusters to manage mood, nausea, and appetite. Trazodone can help with sleep maintenance. We must use with caution given the different symptoms and that patients may already have, so we're not contributing to that with an increased side effect burden. And doxepin, which we use quite often, given its highly selective, potent H1 antagonism, at doses of 3 to 6 at bedtime, really can help with sleep maintenance, and it's FDA approved. And again, thinking about, using one bird feeder to feed many birds. And so if someone has neuropathic pain and problems with sleep, immediately we can consider thinking about the use of gabapentin or pregabalin because it can really help reduce the overactivity of these nerve pathways that have been disrupted by things like chemotherapy. Can it really help enhance slow wave sleep, manage the neuropathic pain? So really thinking about using one medication to manage both. And in instances where people have primary sleep onset insomnia or steroid induced, such as it may be the case when people are undergoing different chemotherapy regimens, thinking about the Z drugs, PRN usage, or in the hospital PRN usage, so we're not contributing to tolerance, dependence, or the risk of paradoxical behaviors. The DORAs are being used, so the dual orexin receptor antagonists, which block the wakefulness promoting system. And so, this is an area, interestingly, of burgeoning interest and study in our patients with cancer, and we're using these agents more often. So thinking about a case, a patient 54 years old, stage 2 breast cancer on an aromatase inhibitor, exemestane, anxious throughout the day, sweating at night, her ISI is high, 22, so night sweats from the exemestane. She's distressed, she's anxious, probably being perpetuated in the evening hours when she's unable to sleep. ISI is high. So is this insomnia related to the exemestane? Is it related to the vasomotor symptoms? Does she also have a comorbid anxiety disorder? Is there also a disrupted circadian rhythm that's here? So many considerations for this person who may benefit from CBTI because that's an opportunity, again, to focus on the cognitions, the stimulus control, cognitive restructuring, as well as the opportunity to make use of medications that are evidence-based, SSRIs, to manage the anxiety and vasomotor symptoms. Sleep consolidation can be attended to with gabapentin, which is efficacious for the management of vasomotor symptoms as well. And again, the DORAs and the role of melatonin in this patient population that has been studied over many years and is growing more interest again as potentially something that might have antioxidant, anti-tumor potential in patients with breast cancer. And ideally, it's best to avoid benzodiazepines. I'll conclude by showing you the guidelines from the National Comprehensive Cancer Network, from the survivorship panel, which focuses, one part of it focuses on sleep, screening, evaluation, and management of sleep. So wonderful opportunity for those of us in this area of medicine and psychiatry to contribute to, and CL psychiatrists were uniquely positioned to attend to these concerns that patients have and really explore the complex etiology of sleep disturbances and disorders in patients with cancer. There's significant neurobiological considerations and a role for not only CBTI, but really to precisely make use of psychopharmacology rather than making use of them as blunt instruments. And then thinking about in the future, how can we scale these interventions for our patients? How can we have more targeted approaches within specific populations of cancer disease, cancer targeted therapies and different cancer types, which I didn't have the opportunity to get into here. And then exploring also the potential for first resynchronization of circadian rhythm. So plenty of opportunities, plenty of interesting areas, both for clinical practice and research. And with that, I'll conclude. These are my references, and I'm always welcome. I always welcome correspondence. So thank you very much, and take good care.